Welcome back to For Mature Audiences Only, presented by Archer Law Office, the podcast where we break down complex aging, caregiving, and elder care topics into clear, practical guidance that you can actually use.
We're your hosts, Mary Shapiro
And Shannon Johnson,
Senior Resource Specialists at Archer Law Office. And each week we sit down with trusted professionals to help older adults and caregivers navigate real-life challenges with less stress and more confidence.
Today, we're tackling one of the most misunderstood and underutilized benefits in healthcare, hospice care. If you ever thought hospice means giving up or believe that it is only the final days of life, this episode may completely change how you see it.
Joining us is Michelle Gadash with Ascend Health. Michelle is a licensed clinical social worker and hospice executive with decades of experience in end-of-life care and palliative care. Michelle helps us demystify hospice, explain who qualifies, what services are covered at 100%, how hospice supports the entire family, and why so many families wait far too long to take advantage of this benefit.
We'll also break down the difference between hospice and palliative care, explain Medicare eligibility, and talk honestly about fear, stigma, and the idea that hospice somehow means losing hope, because that simply isn't true.
If you're caring for an aging parent, supporting a loved one with a serious illness, or planning ahead for yourself, this is an essential conversation. This is For Mature Audiences Only, presented by Archer Law Office. Let's get started.
Joining us today is Michelle Gadash. Michelle is a master's prepared clinical social worker licensed to practice psychotherapy in New Jersey. She has devoted much of her career to hospice and completed postgraduate studies in end-of-life and palliative care at NYU. Over the years, Michelle has served in a variety of roles, including social worker, volunteer coordinator, marketing and business development, regional leadership positions, and executive director. She also has an extensive training and certifications in dementia and memory care, and previously wrote a community advice column called Ask Michelle, where she was answering dementia-related questions for the public. Let's welcome to the show, Michelle Gadash. So to kick things off, Michelle, for those who may not know, can you explain hospice and what it aims to provide?
Sure. Hospice is a program for people with terminal diagnosis, usually 6 months or less to live. We provide symptom management and comfort care for better quality of life at the end of life.
The conversation around hospice, I think, is so great. Last week at a networking meeting that I was at, we got on the topic of it, and the overall consensus that we came to is that it's a misunderstood benefit for people that they often don't take advantage of because they hear the word hospice and then they get kind of freaked out.
Absolutely.
Right?
Absolutely.
Or they think hospice is a place. Like it's
Yes.
somewhere you have to go, that they don't realize hospice goes to you.
Wherever it is that you are.
Right.
Correct.
So yes, I agree with you. People are frightened. They have to just realize, put things into perspective. If it's presented as a program of services that you can have to help benefit you and help you through your journey towards your end of life, I think people would feel a whole lot better about it.
Right.
I think they get scared by that word, just like that big C word. Once they get that diagnosis, they freak out. I think, if we just all kind of take a deep breath and say, okay, hospice is simply a program.
Right.
And the benefit is, available to everyone. And it's a conglomerate of different services put together to make sure that you have comfort and symptom management as you journey through your end of life.
Right.
Can you talk to us a little bit about the team that is involved for hospice?
Sure. So hospice, so Medicare set the guidelines for what is required for a certified hospice, and all others follow suit. So even if it's private insurance that you're using to pay for your services, certainly we would include all of the services that Medicare has set the guidelines for or precedents for. So we would start with a medical director. We have a medical director over all of the services. He or she would guide the care and the plan. We meet at least once every 2 weeks, discuss every patient that's on service. They would oversee the care as well as the RN case manager. That does not mean that you have to use our medical director as your primary care physician.
I was going to say, a lot of people worry that they have to give up their physician.
Not at all.
It works with your physician.
Absolutely. So you have another set of eyes on your care that could make maybe some recommendations or suggestions to your primary care physician.
Sure.
So I didn't know that part about it.
It's always good to have more than less. I mean, and especially when you have someone who really specializes. So if you have a primary care physician, they may not be, a certified, end of life or palliative care physician overseeing that care. So they do that every day. Just like every field, everyone specializes in their own.
Sure, if you have heart issues, you see a cardiologist.
Absolutely.
There are palliative and end-of-life physicians.
Exactly. So we have a medical director. We have an RN case manager. Also within our team, for each patient, they would receive all of these services and benefits. We have a social worker for emotional support. They also would provide resources in case you need, let's say, housing or your insurance. There was issues with, insurance or work issues. You need FMLA. You need, you don't have any food in the house, those kind of services. Those resources, concrete services, and emotional support for the entire family. So people don't realize when you sign on to hospice, it's not just the person receiving the care, it's the entire family unit. When I say family unit, it doesn't have to be traditional family. It could be a partner, it could be a friend, it could be a neighbor, whoever it is that's close to you that's involved in your care. Everyone would be included in that unit of care. So you have a social worker, then you have a chaplain. Chaplains are non-denominational. They're not coming in and pushing religion on you. It's where you want to go with it. If you are religious, then they would pray with you, of course. But if not, they would be another support. Spirituality has many different realms, and they would be there to support that.
And would they, so to speak, that's the kind of role that would reach out if someone was a particular religious faith, but maybe had not practiced in a while.
Absolutely.
But wanted a visit from a priest or
a rabbi. Absolutely.
They would be the ones that could reach out.
To a local, yes. Good point, Mary. They would reach out to get those services if you want last rites or help you with funeral arrangements. There's many different.
Because that, again, takes that burden off of the family.
People don't think about that. When they get that diagnosis, that's the last thing. They don't, but to have things in place prior to, and I always say this because it's a very scary conversation. My background is in clinical social work. So, I put on my social work hat when I speak to these families and I say, hey, look, it's something to think about. We need to plan. It's easier to plan ahead than to have to be, left with that. Yes, when they pass. We need a place to call because obviously we're going to be doing the pronouncement in the home if that's where they live. And we want to know who to call to, the funeral home and at least be able to provide resources for them as well if they don't have the resource. In addition to those services, we also have volunteers. So way back when hospice started, grassroots it was all volunteer. It was volunteerism.
Really?
Yes. It was visiting the sick and helping people. It's kind of like midwifery.
Okay.
So now we have end-of-life doulas, which is kind of the same thing. Back in the day, and that's not too long ago because actually the hospice benefit under Medicare has only been approved, I guess, since 1982.
Yeah.
It's pretty recent. So this is a new program per se. So back in the day, it started as volunteer, just volunteers going out and visiting the sick. And when Medicare decided to make it reimbursable and really find, benefit to being able to provide services to people who were dying at home, instead of being in the hospital,
sure,
it saved money. So they decided that they were going to reimburse for it back in 1982. So when that happened, they decided they didn't want to take away from or, change the whole realm of what hospice was. So they decided to keep volunteers and volunteerism a big part of the program that it's actually in the regulations that 5% of any kind of clinical care, nursing care has to be also provided by 5% of volunteer hours to the hours that the clinical team does.
I don't think people realize that.
Yes. So we do have
volunteer grassroots.
Yes, absolutely. So we have volunteers that do one-on-one visits. I mean, even if it's just to go into the home and sit with a patient while the family goes out and runs errands, goes grocery shopping, even the wife that just wants to go to the hairdresser and get her hair done.
Sure.
Once a week, we would have someone to come and sit with them. And
Oh, I love that.
And
that's great.
And our veterans program as well. So we would have veterans that would go and sit with a vet who may be dying and wants to, talk about their experiences while serving. It's a wonderful benefit. In addition to all of that, so that is what Medicare requires for a certified hospice. In addition to that, since we've been our hospice, Ascend Hospice, has been in operations for 3 decades. So we kind of surpassed, the basic requirements, and we have added on so many other supplementary programs in addition to, which are all under, it's no cost to the family. We have full-time massage therapists, full-time music therapists. We have, obviously pet therapy, which most of the time comes under the volunteer program as well. We have specialty programs, a specialized dementia program for people that are living end-stage dementia. So we have a whole program just geared to and customized to that particular situation.
Sure, that comes with its own special set of needs.
It does. And a cardiac program as well. So all of those services and your medical equipment, your DME, don't forget that. So we're going to probably put a hospital bed to help, care at home, walkers, wheelchair, whatever it is that they need, the medical equipment, medications related to the end stage diagnosis, they're all covered, and any wound care that maybe need to be done, gloves and incontinence supplies and all of that. That's all covered.
Is there a copay? So there's no copay for families then?
No copay. That's all. If they have Medicare, their Medicare Part A is elected, and that is where the hospice benefit is, and everything is paid in full, 100%.
What if someone is too young for Medicare and they have an insurance plan? You work with their insurance plans.
If they have a hospice benefit under their private insurance, of course we're going to utilize that. If they have no insurance, we have charity care. Everyone. Okay, so hospice is a benefit that everyone is entitled to. It is not based on ability to pay, or, if you can't pay for it, you don't get it. Like, sometimes with private home care, if you can't pay privately, you can't have it, fortunately. And it's expensive.
Yes, it is.
But hospice is not like that. If you have the diagnosis and you fit the criteria, and you are your doctor certifies you, 6 months or less, given your diagnosis and the prognosis of your illness, then you are entitled to be on hospice, regardless of your ability to pay.
Wow. I don't think people realize that.
No, and it's so underutilized. It's really sad. It really is.
So that's one of my next questions. Do you have to go out and educate people about everything that you have, right? Is that kind of like an uphill battle that you're kind of always fighting against? Just trying to explain to people what the benefit is and not just getting afraid of the word hospice.
That's the best part of my job. I hate to say it because, as you know, I like to talk. But truly sitting with the family and explaining to them, and their eyes getting big and wide. Wow, all of that.
Right.
I mean, you really can. And I think once they get past the fear of the word hospice, and let me tell you, when I started way back in the 90s, in hospice care myself, working for hospice, a lot of education with the physicians, even doctors. They were like, oh no.
Really?
Kevorkian. It was terrible.
Well,
terrible stigma.
Right.
Attached.
Even from the physicians.
They weren't. Here's the thing. There's no class in med school.
Right.
There's no residency now there is palliative care and all of that, but in end-of-life care, now it's mandated.
I guess it's just an assumption on
they
me
make
that
it a whole day
know.
now. Before they used to get like an hour, like here's the deal, and this is what you do. This is how you give bad news and move on. Well, things are
That's where a lot of the myths came from too, where physicians thought they would lose control of their patients,
absolutely,
et cetera. So it certainly has changed.
They're trained to save lives.
Of course.
And, cure and, doing no harm to me is giving them the benefit and the gift of hospice. Here, we're not stopping. This is not, we're giving you, a gift to transition comfortably. And,
I want to just circle back to a word
Palliative
you brought
care.
up. Exactly. A lot of
Thought you
people
would.
don't understand the difference between what palliative care is and hospice. So can you just talk a little bit about that?
Absolutely, I would be happy to.
Great.
At Ascend Hospice, we do have palliative care as well as hospice care. It's a whole separate department. As a matter of fact, they have another medical director overseeing that program. A lot of hospices or a lot of programs say, oh, we have palliative care. And then they have the hospice nurse go out, and just follow someone that may need some symptom management and then transition them right into hospice. So that's their goal, their end state and end goal, actually. With our program, it's a true palliative care program. We have nurse practitioners that go out and make all of the visits. We have a medical director overseeing all of those patients, making recommendations. Most of our patients right now are in skilled nursing in subacute situations, and they are receiving palliative care visits. And if they meet the criteria for hospice once they're discharged, then we'll be happy to take them on. We're not doing that to make sure that they're going to get the hospice. Sure. Okay. So it's definitely, right now we're not, in homes. We're not doing like one-on-one in the homes, but we are hooking up with some of the facilities and providing in the subacutes. Currently, we have almost 400 patients in the state of New Jersey that we are servicing just on palliative care.
Wow.
So it's a big program. I mean, it's
that is
legit.
a big program.
Wow. So Mary and I love that aspect of it because when we talk about this all the time.
Yeah.
When we have clients that are in skilled nursing facilities, and I've learned this from Mary, try to get them on some sort of palliative care or hospice care.
Just to give them additional support.
Absolutely.
Okay, so here's what's going with that. So people confuse hospice palliative care. So palliative care can be for anyone who has a chronic illness that is suffering, even diabetes, and needs some good symptom management, needs a nurse to kind of look at the whole picture, give them education, even if it is an end stage diagnosis, but they're not quite ready for hospice yet. They're still receiving treatment, or maybe they'll never receive hospice.
Sure.
But it's to help with the conversations, maybe even getting their pulse in order, their end of life care in order, or just for symptom management. I mean, someone with chronic, diabetes, the complications from that would probably make them ineligible for hospice, but diabetes itself won't. And it takes a long time for that to happen. So even if you're in because you had an amputation because, your sugar was so bad, our palliative care can take over. So I always look at it this way. So hospice is palliative care. Palliative care is not hospice.
Okay.
So that's the way you have to look
That's
at
a good way of putting it.
Love that. Great. When would someone be considered appropriate for hospice, and what sort of factors come into play with that?
Okay. Good question. If late referrals come in, and that's what's really sad. People need time to really get into the program, get that symptom management, meet the team, get the benefits from the extra services, and waiting they're actively dying now, so let's put them on hospice, and a day or two they're gone. They don't really get the benefit of what we have to offer. But even backing up from that, people don't realize that just because, you have a terminal diagnosis and the doctor says, 6 months or less, that doesn't, we don't have
There's no crystal ball for that.
None of us know.
There's no crystal ball. So we don't know. We've had patients on a year, 2 years. They have there have been studies, done to say that people live much longer when they elect to use hospice because symptom management has given them better quality of life. So let's say they're in pain, so they're not eating, and then they start breaking down, they get wounds, and then they get infections. So sometimes once that pain is resolved or even managed to a tolerable level, they start to eat more, and then the wounds start to heal, and then they get stronger. And they may even get out of bed. I'm not saying we're curing them by no means, but certainly they will live longer and have a better quality of life in the end.
Are there benefit periods with hospice?
There are.
See how I did
you're
that?
so encouraged. You're so smart, my Mary. So there are. So interesting fact. Again, I'm going to go back in the day. This is very interesting, and I don't think a lot of people realize this. Today, hospice is for any end-stage chronic illness, okay? It's for cardiac. It's for dementia. It's for pulmonary disease.
Not just cancer.
Not just cancer. So way back when I started, hospice was only for cancer patients. If you did not have a cancer diagnosis, you were not getting on hospice. And I think that's kind of where some of that stigma came from. You have cancer, that big C word, you're going to die, and we've come a long way. So back in the day, there were 4 benefit periods. You had literally 6 months. And if you didn't die by your 3rd benefit period, you were coming off.
Really?
Right.
Because you needed that last 30 days when you really started, taking the turn. And that was your lifetime benefit under Medicare. You had 4 benefit periods, and that was it. Now it's unlimited. So you do have benefit periods, and at the end of each one of those benefit certification periods, then there are 60 days or 90 days, whatever it happens to be, you would have to be recertified. You would have to show some kind of decline that you are not, leveling at. It's not custodial care. You have to remember that.
Sure.
This is, showing decline. I mean, I'm saying even if you just lost a pound or 2, even if you we're taking a little more time eating more than you used to, maybe your pain is increased and we had to, or you have a wound, or you had another infection, or something, or maybe even a hospitalization, who knows, or a fall, you're getting weaker. All of those things are taken into consideration. The RN case manager and the medical director, and actually the entire team are documenting on that throughout the benefit period or that certification period, and they're determining or making sure that you're still fitting the criteria that Medicare has set. And if you meet those guidelines, you will be renewed every benefit period, and it's unlimited.
Now, say you graduate from hospice.
I love that. I used to call them flunkies because they flunked out. Like I said, you're a hospice flunky. Good for you. That's the best thing to fail out, right?
But does that mean you're done? Like, say you graduate because you're become eligible for a new treatment, or you're just not meeting the criteria anymore, but now fast forward 6 months to a year, can you go back on hospice?
Absolutely. You are always entitled to come back on. You sign off at any time, even if you change your mind, even if it's like, oh no, this is just too much.
Because nobody can force you
Exactly.
to benefit.
Exactly. Or I'm not ready for it yet. Or,
Right. Sure.
I want to take that European trip and I don't care. My family's going to schlep me around in a wheelchair and I'm going to do this. This is my last hurrah. And God bless you. Go do it. You know what I mean?
Right.
Come off and do your thing and come back on. As long as you meet that criteria, everyone, we're very compliant and we're very diligent about making sure each and every patient on Ascend's hospice's, census is, legit.
I think that's important for people to know too, because I think so many people think it's written in stone that that I'm going on hospice.
And that's it.
And not seeing it as just a program that you're entering that you can leave for whatever reason.
Absolutely. Absolutely.
Let's talk about your journey getting into this whole healthcare conglomerate as a whole, because you said, You're a licensed social worker. That's how you got started in the field. So
Absolutely.
what brought you there, and what brought you to here now where you are?
Okay, so way back in the day, I started out in nursing, believe it or not. And unfortunately, while I was actually in my third year in a BSN program, actually at Bloomfield College, New Jersey. I'm giving you a little plug there. Anyway, when I was in nursing school, my stepdad, unfortunately, was diagnosed with Huntington's disease. A horrible neurogenic disease. It was horrible, actually. So I was a young adult, I guess late teens, like 19, 20 years old. I elected to leave school and come home and help. My mom had to oversee the family business, so she was running that, and I was, one of my sisters and I took on a big part of that role, as well as my mom.
So you were caregiving at a young age.
I was a caregiver, correct. Eventually, he was placed in long-term care, and he was put on hospice. And it just was a great experience. As a matter of fact, it was this hospice. It was Garden State Hospice at the time. We had a wonderful experience. And then when I went back to school and then became a social worker and decided, when I graduated, I applied to the VNA of Central Jersey. Yes. And they said, we have a position for you in hospice. I was like, ooh, what? Like, okay, let's give it a try. I have to tell you, it's been, a big part. I knew it was wonderful when we had those services with my stepdad, but it was even more wonderful, once I...
And you were the one impacting other family.
Yes, I didn't realize how gratifying, it truly is. It's a gift every day, an honor every day to be involved. This is the most intimate time of someone's life. And I always say this to people, there's no do-over. You either get it right this time or there's no do-over, no regrets. I don't want anyone to have any regrets. And I do tell the families that. I say, look, we do this every day. And we want to help you foresee issues, foresee problems. We want to make this transition for you as smooth and as, person-centered as we can. We want to give you the gift of not having to struggle more than you have to.
Sure.
So
we encourage our families to call a couple different agencies.
Absolutely.
If they're, again, we've talked in our other episodes about, just being handed a list and pick from a list, and
not every
they need to call correct.
Exactly. It's not. And like I said, we've had 3 decades to get this right.
Sure.
I mean, in order to be able to. And here's the thing, even your initial interview with someone, another, hospice, I mean, certainly you can tell whether or not you're going to, jive with them. You can tell whether or not, simply asking about the person that's coming on,
who's coming into the home, or who's going to go visit their loved one.
Exactly. Or even asking, what did they do for a living?
Sure.
Who are they?
Sure.
Who are they as a person? We go right for that. Were they a veteran? We need to honor them. We need to do these things. We have limited time, and let's make the best of it. Let's make this journey as, a quality of life and it is, meaningful as possible.
And if someone, say, does start off with a relationship because they were starting to work with this one company, can they switch to another hospice?
Oh my gosh, absolutely. That's a great question.
I don't think people realize there's choices.
So, yeah. And this is crazy. It's going to sound crazy, but I'm going to say it anyway. When I started, there were maybe a handful, 4 hospices in the entire state of New Jersey. There are over 100 certified hospice companies in the state of New Jersey. There are many choices. There are new ones popping up every day. There are ones that get it right all the time. And then there are ones that don't. But I do have to tell you, no one's perfect. We're all going to make mistakes.
Sure.
But give whatever hospice, the opportunity to make things right. If you're not happy, they don't know it's broke unless,
Sure, you talk about
unless you talk about it. No one's perfect, but some hospices do get it right. some, are growing, there's growing pains out there. But yes, if you're not happy and you're not getting, even after discussing issues, you're just not satisfied, then you have every right to, change hospices.
We've been in that position in this role with being an advocate for families and, families telling us we had XYZ company, but we really want ABC company. So we will help, encourage them to advocate for themselves. And,
and sometimes you're not even given a list. Sometimes it depends on where you are.
That's a good point.
that is a good point.
Medicare says you have to give choice.
Right.
But sometimes there is no choice. Sometimes you said, this is the hospice we use. So we've called them. We got the ball rolling. The nurse will be in to see you. In the hospitals, that happens, a lot. Whether they own their own hospice or they use one particular hospice. And, I get that you get comfortable using, but you do have to give it, I would say, at least 2 to 3 choices. Hey, look, we use this hospice, but there was these other ones. Why don't you call them? I mean, it's kind of like,
I know. I have hospice in my background.
Right.
And I always encouraged when families were interviewing me to interview other people.
Absolutely.
Because it is the most important relationship you're going to form.
It's the truth. It's the last.
Correct.
And it's a lasting, like I said, we don't get a do-over. This is like, sometimes you can't fix it. And it's, and it leaves the impressions on the families. I'll never use hospice again. I had the worst experience, or, we're traumatized. Like, well, it's a wonderful, service and wonderful program. And there's many out there. Just, you have to pick the right one that they're comfortable. They have to do the research.
A lot of that also, I think, goes into the part of the families are coming to you in crisis mode. If they have a family that's, they're just looking for somebody to, you never think your loved ones were going to pass away. Right. So you're always looking for somebody to blame. This happened because of this,
the truth.
Or this happened wrong because of this. And, you kind of got to take it with a grain of salt because they're in such a heightened emotional state.
I agree with you.
True. That's true.
I had a director of nursing that I used to work with that as soon as we had a resident of ours that went on hospice, she was always with that family. And a big word that she would use is dignity. We want to make sure that this person is, wherever they are in their journey,
that's right,
they're having a dignified care. So she would always push it on the families, kind of, wherever that person was in their journey, to get all those extra benefits. And then the families, in wherever their loved one was, it was such an easier transition for them if their loved one did pass because, they had all the services leading up to the end of it. So I think it is just a great benefit that a lot of people should take more advantage of. And that's leading up to my question was, do you find where you get patients they probably should have been with you 3, 4, 5 months ago?
Absolutely. There's always late referrals. And I have to tell you, with our, obviously, the surveys that come back, they're always, once someone's admitted and then the services are provided. The Press-Ganey, I think, is our surveyor. They send the surveys to the families after the services are done. The running theme is we should have done this a whole lot sooner.
Sure.
Not that they feel like they could have had, it would have made things easier. Not that they weren't given great service, they didn't have time for it, the services. It's just that they would have, had more information quicker and
that's
longer,
where I think
prepared.
Conversations like this need to happen when folks aren't in crisis, when they can process information differently, when they can recognize.
That's right.
It's so all the benefits there are to a hospice program.
Even if it's too early, which sometimes that does happen. They're like, I'm getting hospice. I don't care. Let's well, even if it's too early, at least, there's nothing wrong with going out and doing an evaluation, right?
Right.
We'll check it out. We'll check medical information. Right. If they're not ready, okay, we can check back. But certainly, always I mean, if you find that there's no more treatment available and you're having symptoms and you want good quality care, and whether it be, if you're going home or you're in a nursing home or an assisted living or wherever it is that you live, that's where your service would be provided. And that's what we could do for you.
I think a piece too that I always hear along with hospice is hope, that I'm going to quote, give up hope. And I think the conversation needs to change to hospice aggressively treats the symptoms, but this isn't something that is curable, but we can aggressively treat what symptoms are coming up. And that is something
I agree.
I know I've used in conversations with my own family members.
Right. It's not about losing hope. As a matter of fact, I always present it as a gift. We're giving you this gift to help you through this because you know what? This might be your first journey with this, but we do this every day and we can get it right. You don't want to have any regrets. You want to make sure that your loved one is comfortable. Again, back to the, getting it right the first time. So yeah, it's a gift. You're not, giving up on hope, for sure.
I always just like to focus on it doesn't mean that it's the end of anything.
Yeah,
correct.
I, again, had a resident that used to live in our building she was a dementia patient in her 90s, diagnosed with cancer. The family obviously wasn't going to pursue any care. They were put on hospice with the plans of thinking that their mom was going to last 3 or 4 months. She ended up living for another 2 years. And I remember she was able to see her great-granddaughter came to the building on her graduation day and all of her stuff, and she was able to see that. And the family said,
that's beautiful.
Had we not had this in place with all this extra care, she may have already passed.
Exactly.
Right? She lived another 2 years after that. So it doesn't necessarily mean the end.
And it's extra eyes on. It's extra care. Like, think about it. You're getting personalized care. What better gift is that? I've even said that to physicians. Like, this is a gift to your patient. Like, we're going to be there to, help them through this. Like, I mean, that's a reflection on you. Like, good care. Like, instead of say, well, there's not a whole lot more I can do, but I'm not putting you on hospice because, or string you along and give you treatments that aren't working anymore.
The thing with the physicians really surprises me. I guess just as an assumption, I would figure that they would know exactly the kind of benefits the hospice will provide for their patients.
I know, but think about when it started, how they were so locked into, they had to guarantee someone was going to pass in 6 months.
Yeah. Now it's pretty much in your honest professional opinion, given the prognosis and the diagnosis, do you think this person will be alive in 6 months? And if they say no, that's all Medicare can ask from them.
Yeah. It's an unfair question to ask.
Yeah, it is. But unfortunately, that's the benefit.
Yeah.
So.
All right, Michelle, we cannot end this podcast without talking about Guru. So
Healthcare guru.
Healthcare Gurus on Facebook is something. Well, I'll let you kind of describe what Healthcare Gurus is.
Healthcare Gurus is one of my babies for sure. It's a place that healthcare, I guess, providers can go to. It's a social media group. I started it 8 years ago now, I believe it is, which is crazy because my original intention was I had so many healthcare friends on Facebook, and I wanted a place for us all to go so that we can discuss work issues and, maybe share referrals and do those kinds of things, and more of a professional level than, on our regular Facebook where everyone's going to, our families and friends, they don't want to be bothered with that. So we started the healthcare group just literally with 50 of my closest friends, and it grew. And it grew and it grew. And people were inviting. So I always say, remember that old hair? What was it? She told two friends.
Oh,
she told two friends. And, okay, so that's kind of the way I look at it. Like, oh my gosh, it just grew beyond. Right now, we're almost at 2,000 members.
Wow.
I know, in 8 years, but we're very particular. Everyone is vetted. Everyone is
you screen and really
I do.
As you should.
And I want everyone in the group to feel comfortable. I want them to be safe from scammers or whatever.
And you don't let people can't advertise.
No. Well, here's the
It's a
thing.
different.
Everyone knows what everyone does. When they're
Right.
introduced, every person is introduced individually. They're able to tell everyone what they do, where they're from. We do share a lot of referrals. We share job opportunities or, positions that may be open. We share events that are happening in the community. We share promotions.
Right.
If let's say an agency is adding on another service, they can definitely talk about that. That's not an issue.
It's a resource center.
It really is a resource center.
Good. That's nice to hear. And
It's
it
a resource
is,
center, yeah.
too. Because people will come on and say, hey, look, whose services?
Right.
Yes, I need a home care.
I've done it.
Take Medicaid.
I've done it.
Straight Medicaid, and I need them like now. And they've got like 10 people answering them saying, we can do it, we can do it, we can do it. And that's a wonderful thing, a place to go. And even like there's a lot of times it's like someone will come to me and ask me, who does this or where, or do you have a contact at this place? You know what? People move around a lot in
Yes,
this
they do.
industry.
Yes.
So it's good to go to a place to like find out who's where and what's happening. And even if you don't know, you can just put it out there.
Right.
And it's such a polite forum, I have to tell you.
It is.
I've never
It
had
is.
anyone get snarky.
It's very
or-
professional.
Extremely. And I'm so proud of, as a matter of fact, last year, was it this year? Last year, we received a Community Connections Leadership Award. And I'm very proud of that for starting this group. It was huge help and resource during COVID as well. And like
Sure, when people couldn't see each other, it was a place to go to get information.
Yeah.
Like you said, find out resources where you could put a question up there and know you were going to get answers.
Absolutely.
And you do a great job of welcoming new people to the group. Hey, it's such and such. Feel free to reach out and do something. You see 100 comments. Welcome to the field. Welcome to the
We have
group.
such a great group. I just love our group. And Mary is one of our administrators.
I'm a
too.
silent administrator. I'm backup.
She's watching.
Backup because you really run the show.
But I wanted to bring that up to say it is truly a resource, and that's what this podcast is really all about. Another place where professionals in the industry can go to find more resources for themselves.
Seriously, look us up. It's Healthcare Guru Professional Networking Forum, and it's on Facebook.
And it's how I got into the field also. So
That's awesome.
Yeah. 5 years ago, here we are. It seemed like I can't believe it was that long ago. Yeah.
Congrats. That's awesome. Thanks for the plug.
Absolutely. Michelle, thank you so much for coming today. Thank you for sharing your insights on hospice. Again, it's such an important, I think, benefit that's just not utilized enough.
No, it's a conversation that needs to continue to happen.
Absolutely.
I agree. A lot
sharing.
of education still needs to be done, unfortunately, after all of these years. But I can't thank you enough. I mean, I know Ascend Hospice is, honored to have been highlighted in this episode. And I have to tell you, I appreciate you both so much. And I'm honored to have been asked to be a guest today. Thank you.
Absolutely. Thanks for tuning in to another episode of For Mature Audiences Only, presented by Archer Law Office. If you found this episode helpful, please be sure to subscribe, leave a review, and share it with someone that could benefit.
Just remember, you don't have to navigate aging or caregiving alone.
If today's conversation raised questions about elder law, long-term care, or planning ahead, visit jerseyelderlaw.com or call 609-842-9200 to find resources and support.
This is For Mature Audiences Only, presented by Archer Law Office. Until next time, keep pushing forward and keep the conversation going.